So, good evening and welcome to one and all. I am Shweta from Clarnet, the designated session assistant for a seamless experience of the session. Clarnet is very proud to be a digital partner for this event organized by Indian College of Anesthesiologists, and the topic of today's session is Pediatric Anesthesia. Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Let's begin today's session, for which I would like to hand over the session to Dr. Radhakrishnan sir. Over to you, sir.
Thank you, Sweta, for airing us. Good evening and welcome you all to this ICA webinar from wherever you are. Friends, this is our 153rd episode and we are so happy. Without any problem, we are able to run this particular academic program continuously on every Wednesday. And in another 2 episodes, precisely on 12th July, we're going to mark our 3rd year of completion of doing this webinar. Probably, we're going to get into the world records of the Guinness. Well, friends, today's webinar is of a different sort. We discuss many areas in the pediatric anesthesia, but certain aspects which are rather serious, we rather drop out in the past, and we are bringing these topics under non-technical skills, non-operating room anesthesia through Dr. Mukul Kapoor, who is a moderator of this particular session. Dr. Mukul, well, you know very well, an accomplished anesthesiologist and an educator. He is a chief consultant, head of the department, professor at Amrita Hospital, Faridabad. Earlier, he had a long period of service with the Indian Army Medical Corps. After that, settled on the private sector in New Delhi. And he is the editor for our yearbook of anesthesiology, which is another product which is really worthy of possessing, reading, and possessing it. And Mukul, along with his friends, Ketan and Niti, will be doing the topics today, and more will be introducing them in due course. Certain other things which I would like to tell you. Well, friends, we're going to have our national annual at Bangalore on November 2, 3, 4, and 5. And November 2 is a workshop to start with, and 3, 4, and 5 with the core academic sessions. And a day is reserved for the postgraduates, rather kept for mentoring them, taking their deficits or reasoning or drawbacks and considerations. We are introducing some areas where they should come up, ask equal to us. That will be our mentoring session on the last day. And the conference is going to be done at NORA and associated hospitals at Bangalore. And Dr. Moderator Kanchi, who is our Dean on the Academics, will be running the program. And all postgraduates of India in anesthesiology are welcome to present their papers if they like, because as stands today, the National Medical Commission would like every postgraduate to do a paper presentation in a year. And we warmly welcome them to come out for that and do the presentation. In fact, we are keeping 1 day separate for the mentoring as well as for the persons. So the dates 2, 3, 4, and 5 of November, get prepared to go out to Bangalore. And regarding our yearbook, well, 2022 yearbook is now available, and 2023 is in preparation, which is going to be released during the conference. And about our courses, well, we are running courses in certain areas, say in transplants, say in cardiac anesthesia, difficult orthopedics, difficult obstetrics, and in ultrasonography also. Now we're going to introduce next month a course in the palliative care also. And palliative care, we're going to run 2 courses. One for the public of India, that means a course for the volunteers who are willing to save some ways with the palliative care of the patients. Other one will be a foundation course or a basic course in palliative course. The course may start sometime by July and going to be online course, and their on-hand experiences will be through some hospitals in Delhi where palliative care program is going on. And once again, I request you to all become members of Indian College of Anesthesiologists and make the ICA stronger, because ICA, as you know, has links with the Society for Ambulatory Anesthesia USA, as well as American Society for Anesthesiologists, as well as Royal College of Anesthesiologists UK, and make ICA strong. This is an academic society, and only for academics we work. And we are sure that we will be able to come up to your expectation, as well as to improve the quality and the credibility of anesthesiologists of India. With these words, I request Mukul to start off the program for the day. Thank you, Mukul.
Thank you, Radhakrishnan sir, and thank you ICA for giving us another opportunity to present our webinars. And today we have chosen again pediatric anesthesia as the topic to be discussed. And in pediatric anesthesia, we have tried to cover topics which are normally not discussed in webinars. So we start with the first topic. Dr. Ketan, will you share your slides? Start sharing your slides. I'll be talking in the meantime. Okay. So in pediatric anesthesia, if you see, there are lots of topics which we have been covering. We talk about airways, etc., about body weight, about physiology, etc. But nobody talks about non-technical skills in pediatric anesthesia, which is something very important. We talk about non-technical skills in running operation theaters, etc. And as anesthesiologists, adult anesthesiologists, nobody talks about non-technical skills as far as pediatric anesthesia is concerned. This is a different ball game altogether. It's you have to learn these non-technical skills if you want to succeed as a pediatric anesthetist. And to talk on this, we have Dr. Ketan Kulkarni. Dr. Ketan Kulkarni is a senior consultant pediatric anesthesia at Amrita Hospital and Amrita School of Medicine, Faridabad. And he is an accomplished pediatric anesthesiologist. He did his DM in the second batch of DM in this country. And apart from that, he has got great experience as far as ultrasound blocks are concerned in pediatrics, in cannulations in pediatrics. And one has to learn from him lots of things as far as handling of children is concerned. His publications are on display. And I would say that he's a very practical pediatric anesthesiologist. It will be good to learn from him. Over to you, Ketan. Ketan, you're mute. Ketan, you're mute.
Sorry. So thank you very much for that kind introduction, sir. So yeah, let's start on this. With this topic: pediatric anesthesia, non-technical skills. Before I start, some disclosures. There are no any financial associations. Even I would like to have some. In my slides, you will see multiple products I'm showing, but no associations. I'm going to ruffle some feathers, like bee swan. I don't know. Swan is basically an Indian mythological bird. Whenever water and milk is presented to him, he'll only take milk and he'll discard the water. So in my presentation, there will be some things which will not appeal to you. So you just take whatever you feel it's right and discard, which don't. Usually, as Mukul sir just said, usually in any pediatric anesthesia conference or workshop or any discussions, we usually revolve around how they are anatomically different, how they are physiologically different, their horizontal ribs and anterior larynx and high oxygen consumption and blah, blah, blah. But today we are going to talk about the psychology of the child, compassionate approach, and our empathetic behavior towards them. And as you know, that there is a difference between sympathy and empathy. Sympathy is, oh, I'm sorry that you are in pain. But empathy is you go to their level, see what's wrong with them, and then it's like, I feel your pain. Now you must have seen Kuch Kuch Hota Hai. So he is this famous boy from that movie. Now imagine a scenario. Now he is coming in for a surgery. He is not fully convinced that why is he undergoing knife, but his parents are convinced, and that's why they have brought him to the hospital. After coming to the hospital people, they have removed all his clothes. They have given him some shabby, very loose fitting clothes, which are not comfortable at all. He doesn't like them. On top of that, they have kept him hungry. They have not allowed him to drink or eat anything. And after that, since he got upset because he was hungry and he was crying, these sleeping doctors, they have given him some medicines which have made him basically zonked, bit sleepy, Hindi mein bole to drunk. So from this happy, bubbly child, he's gone like completely bonkers. So he's become anxious to more anxious. So what can we do to basically make this experience better, less stressful? There are various things, and there are so many things. It's a very huge topic, vast topic, but this definitely, as an anesthetist, we can do. And the most stressful part of any hospital visit is anesthesia induction. Apart from that, you can see you can intervene at various levels, like pre-op visits, post-op visits, their pain management rounds. So there are so many, your hospital ambience overall, training of nurses. So it's a huge topic. So, but we'll restrict ourselves only to the induction because it is most stressful part, and also this is a part where we can contribute to the fullest. According to APA, the definition of anxiety is an emotion characterized by feeling of tension, worried thoughts, and physical changes like increase in blood pressure. Again, it's like Chatur Ramlingam definition. But in simple words, it is dar. Marathi bollo tar bhiti, and I think in Malayalam it is called pedi. So what happens? What is wrong with anxiety? The kids cry all the time. There is nothing new. They cry when we are brushing their teeth. They cry when they are going to the school, but they eventually come out of it. So what's the big deal? Why should we treat them? I think this approach we need to change, and there is a lot of literature available why it should be, why we should not just consider anxiety is just one more thing. We should address it because emergence delirium. So those who are more anxious, they are more prone to get emergence delirium in the post-op period. With emergence delirium, the cannulas come out, the dressings, they come out. If you lose the cannula after, and there is after that there is some complication, then it is a disaster. Also, there is increased chance of post-operative bleeding. Their analgesic requirements go up, and eventually there is poor pain management. Sleep disturbance is not only restricted to the hospital stay, but it also carries on even when they go home. So there will be night terrors, horror, like bedwetting, enuresis. And obviously, when this horrified child is coming in for the next time, there will be problems at the next visit as well. And ethically also is very important that we deal with this anxiety and just not accept it. So that what are the various factors? So there are patient factors, environmental factors, parental factors, and anesthesia factors. So in patient factors, personality and age, there is nothing much we can do to improve or to modulate this, but we'll see what we can do in subsequently. Personality is very like high intellectual or like sharp, clever children. They will have more anxiety because I think they understand a lot of things. Age less than 6 months, it's basically the physiology. They are not anxious at all. After 6 months, there's some books also mentioned that it is 1 year. After that, they'll get the separation anxiety. They just don't want to get away from their mom or dad. And depending on the age group, they will have different kinds of anxiety. Like in teenagers, they are more worried about not waking up from the sleep or mutilation. Like in school age, they are more worried about post-operative pain management or post-operative pain per se. In other factors, in parental factors, those who are from high affluent class and those who are like more educated, their children, they will have more anxiety. The children who are accompanied by their mothers, they will have more anxiety. Divorcee parents, single parents, and kid with no sibling, they will have more anxiety. Environmental factors, this is obvious: long waiting time, crowded room, not very good ambience of the room. They will get anxious. Trypanophobia. Can anyone write in the chat box what is trypanophobia? I'll cover the rest of the things. I am not able. I don't think I'll be able to see the responses. Anyway, so trypanophobia is basically fear of needles. So there is something which we can definitely do as an anesthetist. We can give them an option, like whether do you want to go with the cannula at back of your hand or gas. So I think most of the kids, they will prefer gas because inherently they are not very good with needles. Untrained personnel, it's not only the anesthetist with less experience. Overall, the staff in the theater, anesthesia technician, the nurses, everyone, they have done studies and they have found out like less training in all these people, they cause more anxiety in the kid. Obviously, previous negative anesthesia experiences and the children who are coming in for the first time, they will have more anxiety. So if they are coming in for the first time, if we give them a nice conducive environment for going off to sleep, it will be less problematic when they are coming in for the next time. So now we are basically talking about the non-technical skills. What do we mean by non-technical skills? So first is communication. Their needs are unique. They are not coming in for the surgery. They are not interested in getting the surgery done. It's either their parents or someone else who is more interested in fixing the issue for them. So they are coming in a very like reluctant way to the hospital. Ice breaking is tricky. There again, the things which you want to explain to them, they are not interested. Like suppose post-operative pain relief, you want to put an epidural catheter, they are not interested in that. So on what things you are going to start the conversation, on what things you are going to tell them what is what and what is not. So that's the important thing. And in my experience, I feel if you greet the kid first, even before you greet the parents, it creates a wonderful experience. It gives the kid immense confidence in you. So this is something works for me, and I hope it will work for you as well. Second thing is go to their level. Standing over your pediatric patients may make them feel uncomfortable. Whenever possible, either kneel down to them or put them on a chair or sit up. If they are lying down and you are standing up right in front of them, it just scares them. Whenever possible, and most of the times our anesthesia table, not anesthesia, our OT tables, they are flat. So instead of that, if you put them on a trolley and make the backup, they feel it is more comfy environment for them. And when I'm saying go to their level, I'm not just saying by physical means, I'm also saying by the mental means. They are not interested in Ram Mandir Kab Banega or what Kejriwal is going to do in his new educational policy. They are more interested in Chota Bheem, what Chutki is doing, especially if they are non-school going. If they are toddlers, they are more interested in what Peppa Pig is doing, how he is jumping in the muddy puddle and all that stuff. If you go to the school age group, they are interested in Virat Kohli was famous a couple of years back. Now it's Shubman Gill and other accompanying factors. So you need to be aware. You need to keep updated yourself. Now Avengers and this superhero movies, again, you should know. This is about school age children. I wanted to put some interesting images which will interest the teenagers, but I have not put in those. I hope you forgive me. And talk to teenagers like as if they are an adult. So they want to know everything. They don't want this kiddie language. They want it like very precise, brief, crisp. And if you treat them like as an adult, they will also be receptive to your ideas. And there is a concept called as receptive teens. Long story short, basically use clear, simple language that is tailored to the child's developmental level. And what I mean by clear and simple language is, instead of saying don't move, you just give a positive experience saying keep your arm nice and relaxed. Something like might sting is not very well taken by them. You just say a big thrust or a big push you will get. Instead of saying it might hurt a little, instead of say that you are strongest amongst us, you are bravest amongst us. And if you are doing inhalation induction, just avoid this, say like bad smell. You say like it smells like mom's nail varnish, or it smells like Vicks VapoRub. And if you want to make some jokes, you just say it smells like your dad's feet, or someone is farting in there. So you can say all these things, but try to avoid all these negative comments. In communication, one more thing is you have to be honest. You can't basically trick. It's best if you don't trick them. In Indian scenario, it's very difficult, or in Indian setting, it's very, our culture is different. So not tricking is difficult, but I would say you reserve it as a kind of last resort. Inform before you do. Whenever you are changing their position, whenever you are attaching a syringe, or even for that matter, even a pulse oximeter probe, you first tell them. Whenever possible, give them an option, like whether do you want to go off to sleep with the IV at the back of your hand, drip at back of your hand, or face mask. So whenever possible, give them an option. If you are choosing the face mask, you can give them an option about what smell you want in that face mask. So we'll discuss about the smells eventually in the lecture. And most important, I feel, is that try to have one person at a time talk to the child. Unfortunately, even like whenever there is a pediatric case, it's kind of a VIP case. We also get one of our colleagues to help us. The technician also, they will always find one more person to help them. It's usually a crowded rooms. If you are getting the parents also inside for induction, so there will be one or two depending on your hospital policy parents inside. So it's a kind of overwhelming environment. So whenever possible, just keep calm, have minimum interaction, and have quiet room. and one person talk to the child at one time. These are some terminologies. So instead of saying IV catheter, you just say small straw or tube. Inhalational is a special medicine in the air. Syringe is a tube with numbers on it. And all this. SATs is like a peg or clip on your finger. Peg is basically जो चिमटे रहते हैं जो हम कपड़े सुखाने के लिए डालते हैं वो. One more aspect of communication, or one more important thing in communication, is the ambience of the room. So now you are aware, this is very fine and very polished room for adults, but kids are not interested in that. Kids are more interested in something like this, which is having small chairs, lots of toys, very bright in color and colorful rainbows, trees, etc. Whenever they are waiting, if we can basically make an environment where they can play with toys, dolls, or they can do some coloring activities, it keeps them distracted and they are like more relaxed when they are coming in for the procedure. One more thing about this is that this is a very cramped operation theater where you have a lot of equipments, machineries, very darkened room. So they are again and like a flat operation table. So they get more scared when this setup is there. So instead of that, if you have a trolley which is reclining with the walls with some colors and paintings on that, so it gives a better experience for the kid. And in my personal opinion, it's good if this particular room is accessed even without changing clothes. There are two advantages. One is if some autistic kid or something like that comes up, you can because that autistic kid will not like even changing of the clothes. So you can basically take the patient directly into that induction room. And also the parents also can come into this room without change. So it causes less disturbance in the theater operation, like operation of the list per se. Induction techniques, there is nothing new in this. There are only two induction techniques. One is IV and one is inhalational. In IV, you have all these creams which will you put on the dorsum of the hand. For the Prelox and lignocaine is basically you have to keep 1 hour prior, and this tetracaine is, I think, new per se, not very new, but newer than Prelox. So it requires less amount of time. So you just put it for 30 minutes and it numbs the skin. Problems, Prilocaine with hemoglobinia is more of a theoretical risk. I have not seen any patient getting high methemoglobin after Prilox application. In India, mostly this Top Lab and Viveta, they are more famous. Amitop was more famous in UK, yeah. Now this is just to complete the list. Lidocaine iontophoresis and needle-free powder lidocaine is again same work. It basically numbs the area where you are going to put the IV cannula. The results of these two equipments or whatever techniques was not great, and it's kind of discarded. It's just there to complete the list. Inhalational, again, there is nothing new. Use nitrous, no nitrous, oxygen you have to use. Sevoflurane, halothane, these are the only two inhalational agents till now. Xenon might come in the future, but right now it's only sevoflurane and halothane. For induction, you can just go incremental, like 2, 4, 6, 8 for Sevo, or 1, 2, 3, 4, 5 for halothane, depending on the kid. Or you can prime the entire circuit and basically ask the kid to breathe in. To mask this, the smell of Sevo or halothane, you can use different flavors. So these are different flavors which I have in my box. If possible, I give them an option of which flavor of fruit do you want in your face mask. Or you can have Vicks vapor rub, or even simple what nowadays my wife also uses is this lip balm. So you can put it in your this backpack. And now we'll talk something about distraction methods. Now I couldn't find any patient to be suitable for this. So that's why I have asked one of our OT boy, a volunteer, to help us out. In next video, I have purposefully kept the audio on, and there are a few mistakes which we have done in the induction. I'll speak as we progress. So I wanted to use this trumpet, or I don't know what it's called, but I wanted to use that first. But since he was pretty much relaxed and everything, he was very anxious kid, to be honest. And he was not very happy coming in. So that's why he removed his cap also. He was not basically listening to us. And that's why we started with this trumpet. And then when I felt he's okay, I thought we'll go with this basically JR circuit with the bag. Obviously, the JR circuit with the bag will work better than this trumpet attached to the JR circuits. So you can see the background noises, the nurses and everyone, they are talking to each other. And here one more thing we have, basically we tried to make him supine even before he went off to sleep. And that's why we had a small hiccup. So here we tried to do him supine, and that's why he didn't like it. And once he's off to sleep, it's all winning. Anyway, so another thing in distraction is this new balloon which has come up. It's still not available in India, but again, just to complete the list. So instead of blowing the balloon, you are blowing into the balloon. And then slowly you drift off to sleep. Same thing can be used. This pinwheel can also be used. I didn't get the pinwheel, so I couldn't make a video of it. But again, if it is available, you can use the same principle to blow this and distract. Now this VR, virtual reality augmentation, is coming in a big way. Most of the kids, they have it is as a, not most, but many of the kids, they have this in their toy box. You can use it for inhalation induction as shown in here, or you can just put them on and put a IV cannula while they are watching these videos. This is a very high fidelity VR set. Similarly, you can have, so these are my my friends who are using very high fidelity this VR set, or you can just basically buy this online and put your mobile into that. This is very cheap Indian jugaad for that. And oh, the video is not working very well. Okay, fine. And then you can put this, there are a number of YouTube videos available. You just put them on and select them as a VR viewing option, and then you can put that thing on. But personally, I feel the VR sets are better than this Jugado technique. Now these VR sets, they are not only being used for induction per se, but they are also getting used for doing the complete procedure like transthoracic echocardiography. It's a very welcoming tool. All this, when I was working in Birmingham Children's Hospital, there used to be one list where they are doing like all these bone marrow aspirations, lumbar puncture on just VR. There is no anesthesia involved. It's just the kit with VR and they do the procedure. And also they have found out that perioperative anxiolysis, the need for giving midas, clonidine, all the pre-medication is drastically reduced after they have introduced this VR set. Again, there's one more thing, again, distraction device or a toy, you can say. This is very recent. This is launched or came into news on last month. Again, same thing, iPad is attached with one sensor, and you just breathe in, breathe out through that face mask. The iPad with sensor detects it, and there's this game, then there are some awards, and you achieve that goal, and it just keep the kid distracted. Pharmacological anxiolysis, I'm not going to talk much about it. Dr. Niti will cover this in her talk. But again, there is nothing much improved or nothing new drugs have come up except for this melatonin. Again, I personally have not used melatonin, so I'm not very sure about its efficacy and effect, but people are saying it's worth trying and it's equally effective. So let's see in the future. Last, we are now finishing our presentation. The last topic, more important topic, is parental presence during induction. It definitely reduces the kids' anxiety. It increases the cooperation from the children. It reduces the need for pre-medication. So your hospital or OT staff is relatively free. The complications associated with pre-medication are less. When I'm saying complication, I'm not saying the respiratory depression or airway obstruction. They're like very, very rare. I've not seen it. Neither any of senior colleagues have seen it. The main problem especially with midas, is paradoxical excitation, which is more problematic and more frequent than other problems. But the problem with parental presence is it disrupts the OR operation theater routine. So that's why I was saying, if it is possible to get the kid into a separate induction room where the parents are okay to come in even without changing. Need for an additional support staff to escort the parents. If they have come into the room, we need someone to basically guide them. Sometimes they get upset, and there are certain incidences. I have not personally seen it, but many of my colleagues must have witnessed or seen this, that the parents are getting fainted after the kid goes off to sleep. So you have two people to manage. One is kid who you have anesthetized, or you have basically put him off to sleep, and one is gone off to sleep spontaneously. So it becomes more like a medical legal implications, and stress on the anesthesia providers, especially if the parents are standing there and making faces or making some noises, so then it becomes a stressful environment for anesthetists as well. The evidence says that basically if the kid is a frequent flyer, then yes, parental presence during induction helps. But if it is for the first time, it's not very, very useful. Family-centered approach, it's more like I would say it's a UK thing, where they are giving parents and kids hospital tours, video presentations, leaflets, interactive comics and everything. The hospital tours was very famous before COVID, but after that everything became virtual. So every hospital put in a lot of efforts and money to shoot the video, and you can see on YouTube also, like how these hospitals, they are conducting the hospital tours. Again, the information is given, it's not given only to the kid per se, but it is given to the entire family. That's why it is family-centered approach, and it is given to them depending on their level of education, depending on their level of understanding. But yeah, this is something which we don't do till now in our hospital, but yes, we are aspiring to do this. And then this poems course, so those who are those kids who are difficult to manage, like very severe autism or developmental delay or something like that, then this course was there in UK for the parents. So how to cope up with this distressing environment. So, and then you have play therapists who are like trained therapists, trained people who can basically do a lot of stuff. They have various toys, they distract them, it's their job, so that they are very much like professional and trained to do that. How to involve kids into different by different routes. Use of restraint, it's main, I think in Indian scenario, this is the main kind of pakdo, dalo, IV line, dalo. So its use is challenging. It is associated with a lot of dignity, psychological trauma, physical harm, not only to the kid, but also to the staff. So it's, I think after today's presentation, everyone would question themselves before they use this restraint. In ideal world, yes, consent should be there. It should be there from parents, and it should be used as a last resort rather than first resort. A summary, we have seen anesthesia induction is the most stressful event, and how as an anesthetist we can contribute to a lot of things. Importance of managing anxiety, why it is important to reduce the anxiety, what are the communication nuances, distraction techniques, pre-medication, we have just brushed it, and parental presence. Thank you very much. That's all from my side. These are my references. Thank you.
Thank you very much, Ketan. It was a very interesting presentation. I'm sure everybody must have gained a lot. There were actually practical points which everybody can follow, can emulate Ketan, whatever he has described, because children are not easy to handle. That is what we all know, and I'm sure all of you must have faced such problems in your life while delivering anesthesia to children. If you have any queries, any questions, please put them in the chat box, and I'm sure Ketan will be very happy to answer them after the third talk is over. Thank you once again, Ketan. And
thank you, sir. Thanks a lot.
And now we come to the next topic of the day that will be done by Dr. Niti Gulati Batra. Dr. Niti, can you put on your slide, please?
Yes, sir.
So Dr. Niti is a senior consultant with us. She has chosen a very interesting topic, NORA. Non-operative room anesthesia has become a big thing, and as on date today, I have to employ regularly at least 2 anesthetists for the entire day to do NORA procedures. And earlier it used to be just adult NORA procedures, but today things are changing, and we are having to do a lot of pediatric NORA cases in addition to adult NORA cases. And it's a relatively new field as far as anesthesia is concerned, and the challenges are absolutely new to us. And we are sort of trying to find ways and means of doing it in the right way. And to cover this topic, we have Dr. Niti Gulati Batra. Dr. Niti is a senior consultant with us. She's got a lot of interest in ultrasound blocks. Niti, you've not shared your slides.
Okay.
So, and Niti is has done anesthesia from Delhi, and after that she has been practicing in Delhi and Faridabad, and she has come as a senior consultant to Amrita Hospital and Amrita School of Medicine. And here she's taken a lot of interest apart from giving anesthesia in teaching people how to do resuscitation, and she's an expert in resuscitation. She's a regular faculty for airway management also, both in adult as well as in pediatric age group. Over to you, Niti.
Good evening, everyone. Thank you so much, Mukul sir and Balakrishnan sir, for giving me an opportunity. Thank you, ICA. I bring greeting from the Amrita Hospital, and I present the topic for the day is NORA in pediatric patient. So NORA is a beautiful name. It is non-operating room anesthesia. So after coming from a beautiful and interesting conversation with Dr. Ketan, I move on to a territory which is a new territory, right? I am coming out of my comfort zone to a place which is new for me. So now I'll be discussing under these headings, patient-centric, equipment-centric.
Your slides are not on still, not shared screen.
Okay.
Yeah. Yes, they are on now.
Okay, so slide only. So my main objectives are that now we are coming to a territory which is a new territory to me. So I have my patient problem, equipment problem, and procedure-centric challenges. I'll be discussing the fasting guidelines, what is new, the various techniques, intravenous inhalation, and new target control infusion. What are the monitoring that is required as a must, complication that can happen, and whom and where to call for help. New terminology like general anesthesia with endotracheal tube. So while I'm covering the, while I'm going to do a topic which is, I'm going from my territory to a new territory. But again, I need a good PAC, a good pre-anesthesia checkup, but I don't need any investigation for this. There are no lab investigation that are being required for the pediatric age group. I need a thorough understanding of the anatomical and physiological changes in children, knowledge of unique pharmacokinetics and pharmacodynamics of individual drugs, understanding of specific requirement of the procedure. What is the duration, whether the stillness is required or not, whether it is a painful procedure or it is just a diagnostic procedure. Then an effective team communication between anesthesiologists and non-operating room personnel. Because now I'm dealing with those people who I'm not meeting them daily. They are not part of my team. So now, first of all, the 8 specific characteristics, that is the patient-centric challenges for me. So as Ketan has said that they are different. So I'll categorize them in different age group. So for me, a neonate has got different anatomical differences as compared to an adult. He has a large occiput. You need to have a body raise or a shoulder roll place. He has got large tongue and he might pose a difficult IV cannulation. Then they can be associated congenital anomalies. Patient may be preterm or a term baby. Why? Because preterm is more prone for apnea and there are further complications with that. They have got less developed hepatic and renal mechanism, increased volume of distribution for the water soluble of drugs. But again, my drug dosage is catered. Less drug has to be given. It has to be weight based. And they are further prone for hypothermia, bronchospasm, and laryngospasm. Now, if I come to an infant, with an infant, there comes a separate level of problems. Separation anxiety. Yes, cooperation is very difficult. To gain a trust, just now you see how many distraction techniques you have to use to gain the trust of the patient. So pediatric patient is more challenging and more difficult as compared to adult. Why? First, they are not cooperative at all. So what is the thing? Your continuum of sedation will be landing into deep sedation. Then they cannot tolerate hypoxia very well. So they go into the critical hypoxia zone very early. Then they are prone to excitatory movements and behavior problems. And you need an expert who is an expert in giving sedation, in managing the airway problems and resuscitation. Again, an infant is prone for bronchospasm, laryngospasm, airway obstruction, and associated congenital anomalies. Neurological impairment is there. And difficult IV, yes. Now, again, once we have come from the infant to a child, Anil, again, that child-centric problems are there. There is separation anxiety. Emergent delirium is more. Why? Because these children are more anxious. Because now they know more. They have got more knowledge. और जितना they have got more knowledge, they'll be more anxious. And again, problems of bronchospasm, laryngospasm, airway obstruction, obstructive sleep apnea. Their attention span is less, and there might be an autism child. Once we come to adolescent group, there is further fear and anxiety of the procedure. You need to gain the trust of the patient. You have to explain the procedure. Previously, I went for a CT scan. There was already an IV placed on the child, but that child refused, I don't want to sleep. But since I had the consent of guardian and that patient need to be immobilized for CECT, so I had to give him propofol, but he didn't want to put him to sleep. So they are more anxious for the procedure, and they are more prone for the excitatory movements and behavioral reaction. And obviously, cooperation is not well established. Now we come to the equipment-centric problem. One is the physical structure, and the other one is the environment that we can move. In the physical structure, there should be a suction outlet, a gas mount, oxygen and air outlet, adequate lighting, and safe electrical outlets. Anesthesia machine, checked. Size appropriate airway equipment from oropharyngeal airway to supraglottic airway and endotracheal tube. Crash cart trolley, suction catheter, oxygen delivery, IV access supplies, stands, infusion pumps. All the drugs related to anesthesia and the resuscitation drugs. You should have your checklist ready and charts ready, which tells you the weight-wise drug dosage and weight-wise the equipment. And this is a mnemoniac that says SOAP me, suction, oxygen, airway devices, pharmacy including emergency plus the antidotes of the sedative drugs, monitor. E is the equipment that stands for the other electrical equipment, gas scavenging, light and defibrillator. Now comes the procedure-centric challenges. The most important thing is communication. I am working in my OR. I know my staff. I know my technical staff. I know where the things are being placed. But now I'm moving out of my territory. I'm going into a territory which is new, which is not very common. I might be posted once in a week. I may not be posted. I might be posted to set PET CT. Then next time I'm going to MRI. So I should be well versed with the equipment present there, well versed with the staff present there. Then I should know what is the nature of the procedure and what is the requirement per se to that specific procedure. Whether that procedure is painful or it is a diagnostic procedure. What is the duration? Whether the immobility is required or not. What are the possible side effects? Side effects of drugs I know, but what could be the side effects of the position per se? Procedure per se. It could be the position, or it could be that they want to give the contrast. Then what are the equipment and devices used, and how much space I have gone? How much space is given to me to act upon and to move around in that room? So now once we have discussed the challenges from patient, procedure and the equipment, now we come to the first step of PAC, that is now we come to the fasting guidelines. To American Society of Anesthesiologists says that clear liquid should be allowed till 1 hour, breast milk 4 hours, solid food or non-human milk 6 hours. Less than 6 months, this solid food becomes 4 hours. This is from the Journal of Anaesthesiology. They have given this, these are not the guidelines, they have given this review, they have checked all the review and they have found out that there is no, it is not, the fasting is not a independent predictor of aspiration. They have not seen aspiration in any procedural patient, and they have not shown any relationship between the procedural sedation and the fasting status. But you can follow your own hospital protocol. It says that with negligible risk factor, you give clear liquids unrestricted, breast milk unrestricted, non-human milk fasting 2 hours. But if there is some mild risk factors like severe systemic disease, moderate obesity, age less than 1 year, hiatal hernia, or you are going for upper endoscopy, bronchoscopy, or you are using propofol as the principal sedative, then clear liquids is unrestricted. Breast milk 2 hours, solid 4 hours. But suppose if there is a patient who is having severe systemic disease that is a constant threat to life, OSA is there, and you anticipate the need for assisted ventilation or other advanced airway management, then clear liquids 2 hours, breast milk 4 hours, and non-human milk 6 hours. There should be no delay based on the fasting time. Because of the fasting issue, no kid should be delayed the procedural sedation for a procedure which will hamper the management for the patient. Now, once we come to the conduct of anesthesia, again, it starts with the pre-anesthesia checkup, in which we should know the history of the patient. Any congenital anomaly has to be ruled out, any neurological impairment, and any airway abnormality, any upper respiratory tract infection has to be ruled out, whether the baby is a preterm baby or it is a term baby. Investigation, you don't need any investigation for the procedural sedation. Then comes the fasting status and the informed consent from the parent or the guardian. Then there are various non-pharmacological means that have been beautifully discussed by Dr. Ketan. Then there is the intravenous, where there is a use of EMLA cream, but again, you need to have a 1 hour delay time for that. Then inhalation with sevoflurane, halothane, or nitrous oxide. You can go for intermittent drug or you can go for infusion. There is a role of regional anesthesia in the cases where you are dealing with the emergency department, like there is a fracture dislocation or anything that is painful, if you can give a regional block there. These are basically the contraindication for sedation, like abnormal airway, raised intracranial pressure, patient is in cardiac or respiratory failure, neuromuscular disease, bowel obstruction, active respiratory tract infection, known allergy to sedative drug or a previous adverse reaction, refusal by the parent, guardian, or child. Now I'm speaking about this is also very controversial subject, whether it is a sedation, whether we call it a GA or we call it a MAC, that is the monitor anesthesia care. So sedation is a continuum of sedation, and we should always titrate our sedation. And anytime we can move from one continuum or one pendulum to other pendulum. It starts with the mild sedation, conscious sedation or moderate sedation, deep sedation, and general anesthesia. So what is minimal sedation? So minimal sedation is when the patient is responding to verbal commands. It's a drug-induced state where the patient responds normally to verbal commands. Then there is moderate sedation, or it is called conscious sedation. But mind you, for less than 6 years of age, there is no word like conscious sedation. Because as I said, the pediatric patients, they are not very cooperative. And anytime your momentum and your continuum shift from moderate to deep sedation. This is a drug-induced state of sleepiness where the patient responds verbally to light touch or verbal commands. Your airway is maintained. Spontaneous respiration is maintained. Deep sedation it's a drug-induced state of sedation where the patient responds purposely to repeated or painful stimuli, not easily arousable, but respond purposely to painful stimuli. In this case, your respiration need to be assisted, but your cardiovascular status is maintained. Then there is a continuum movement to general anesthesia. This is a drug-induced state where the patient is unarousable to painful stimuli. As per the American College of Emergency Physician, giving sedation with or without analgesia to induce a state that allows to tolerate unpleasant procedures while maintaining cardiorespiratory function. So they are different category. Now I need to know whether I want to give sedation for my procedure, whether I need to club sedation with analgesia, or just dissociation is required, or whether general anesthesia is required for my procedure. Sedation is you want to make him amnesic, that he is not able to feel anything unpleasant. Analgesia to give pain relief. And dissociation is a trance-like state where patient is not feeling any pain. He is amnesic, but he is maintaining his airway reflexes and cardiorespiratory function is maintained in this state. There are certain sedation scale. One is the Ramsay sedation scale and other one is the pediatric sedation state scale. Ramsay sedation scale has given numbering: anxiolytic 2 to 3, moderate sedation 4 to 5, deep sedation 6, anesthesia 7 to 8. This is the pediatric sedation state scale, which consider all these parameters: movement, stress, pain, respiration, blood pressure, and heart rate. This score says 5 is moving purposefully, 4 moving during the procedure, 3 expression of fear or anxiety, 2 quiet sleep, 1 deep sleep with normal parameters, 0 is deep sleep with abnormal parameters, that is SpO2 is less than 90% or there is bradycardia. Now we come to the monitoring. So we need to have standard monitoring during the procedure: electrocardiogram, pulse oximetry, temperature, and end-tidal carbon dioxide if we are using general endotracheal anesthesia or we are using a supraglottic airway device. There are certain limitations in MRI suite, and we need to have machine, we need to have monitor that is compatible with the MRI suite. There we can have monitoring ECG, pulse oximeter, and blood pressure. And I think we need to have a capnograph also in the MRI suite, because I was giving MRI to an adult patient. He was a difficult airway case. I was inside the MRI suite and I was monitoring, and suddenly my monitor was not giving me a correct information, but I was just confused whether sometimes it is coming and sometimes it is not coming. And once I was just taking out the patient after the procedure, the patient was unresponsive. We could revive, but again, there was hypoxic damage to the patient. So there are certain limitations in the MRI suite, and we need to have good monitoring in MRI suite also. Transport capability. There should be a good transport monitor and oxygen delivery system while we are transporting the patient from the procedural room to the observation room. So now we come to the drugs. So do we have an ideal drug? What is an ideal drug? An ideal drug is a drug with minimal side effect, which has got a rapid onset, which has got a rapid offset, which is giving sedation plus analgesia both. Then no hemodynamic changes are there and less emetogenic. So let's talk about the drugs. The list is very long. There are certain individual drugs and there are combination drugs, and I think combination drugs are better. So while we come to the individual drugs, midazolam is the drug which has been used since ages. It's being used in every form: oral, intranasal, rectal, IV, and oral it can be mixed with 25% dextrose. So what is the advantage of midazolam? Yes, midazolam gives good enzeolysis, but the first hepatic metabolism by oral route and rectal route is unpredictable. Intranasal gives you irritability. It takes onset of 20 to 30 minutes if you're giving oral. And after midazolam IV, the patient can have disorientation, can have emergence delirium, the child can have inconsolable crying. Ketamine. Ketamine also we can use with different routes: IV, oral, IM, rectal. Initially, it was being used very well. Later, it became a disputable drug, but again, it's being used in the sub-anesthetic doses. And if we are using ketamine, 0.5 to 1 milligram per kg, it is a very wonderful drug. It is a good analgesia. It can be used as a dissociative drug. Your airway is intact and your cardiorespiratory is also intact. Dexmedetomidine is a new drug which can be used as nebulization. It can be used as nasal drug. It can be used IV. But again, onset is a bit delayed. Duration is a bit prolonged. You need to give infusion. Then you have to watch for the patient. But it is a very good drug which gives sedation, analgesia, and respiration is being maintained. Fentanyl is being used if we are doing a painful procedure. Again, clonidine is used. This is also an alpha-2 agonist, just like desmetamidine. It can be used oral, but again, you need to give half an hour for the patient to give this drug, and then you have to plan that way. Propofol is a very good drug. Propofol has got a rapid onset and it is less emetogenic. And the beauty of propofol is that the dose in which hypnosis is maintained, you get hypnosis, in that dose, your respiration is, spontaneous respiration is maintained. So in that case, propofol is a very good drug, but again, it is painful on injection. It can cause hypertension and bradycardia. It can cause apnea. Then there is remifentanil. We don't have remifentanil, and I don't have any experience with remifentanil also. This is again, you have to use bolus and then followed by infusion. This also got a rapid onset and rapid offset drug. Melatonin is also a new on the platter. I have not used, I don't have any experience with melatonin, but according to the literature, it gives a good oral natural sleep. It is an oral drug, it good natural sleep, but again, the onset is a problem. Now we come to the combination of drugs. I think combination is better because your side effects are being merged. You can have the benefit of one drug and you can decrease the dose of the other drug. Ketofol is a very popular combination, ketamine and propofol. Then there is a dex kit, dexmedetomidine and ketamine, fentanyl plus midazolam, remifentanil plus midazolam. And along with this platter, you should also have your antidotes ready, flumazenil and naloxone. And you have to monitor your patient because you have to keep on repeating these antidotes because the duration of these drugs is lesser than your sedatives. Other drugs to complete the list is intravenous etomidate and chlorohydrate. Chlorohydrate, again, I have not used it. It's got a very bad taste and very pungent odor. Inhalation, you can use sevoflurane and halothane. If you have got a machine, I think it's very good that you use inhalation. You can use sevoflurane, you can put a supraglottic airway device, and then you can take an IV. Then nitrous oxide is also a very beautiful drug because it has got a minimum effects on the airway, minimum cardiorespiratory effects. Your onset is just 30 seconds and it just goes off in 5 minutes. You can use supraglottic airway, you can use general anesthesia, general endotracheal anesthesia. And there might be scavenging. I don't think so. There will be no scavenging in that room. These are the newer things that's coming. That is the target control infusion and the closed loop anesthesia delivery system. TCI works on the Marsh and Schneider model, and they work on this principle, bed principle, that is bolus elimination, and then the drug moving from central to peripheral compartment. CLADs work on a computerized based operating system with built-in algorithms, and the effect is a target control variable, that is BIS, and actuated is a drug delivery system, that is the syringe pump. Now, if we come to these special circumstances like specific challenges that is there in different NORA, because every time it's not just one NORA, it's everything outside my operating room. It can be MRI, where there's a motion-free artifact is required. The patient needs to be still. There should be no movement. You just need sedation and stillness. Then the radiotherapy, PET CT, there is a risk of radioisotope exposure from the kid to the other people, the staff and the doctors around. So 4 to 6 hours gap is required. Then again, in kids, if you are going for CT and PET CT, you have to keep in mind ALARA, as low as reasonably achievable radiation. In endoscopy and in bronchoscopy, again, there is a sharing of airway. Neuro lab, cardiac lab, cath lab, even TE we are required. In dental procedures, we are required. In dental procedures, they use nitrous, they use oral, they use inhalational. In burns dressing, ketamine has a good role. Then bone marrow biopsy, lumbar puncture, chemoport, Hickman insertion, fracture dislocation. The list is endless, because as an anesthetist outside the OT room, there's a lot of places where you are just required for giving the sedation. But that continuum of sedation, we have to be careful about. So we need to be well equipped. This is the MRI suite in Amrita Hospital. The image on the left side, you can see this is from the console. There's a partition from which you cannot see it clearly also. So you can see I'm not able to clearly see my monitor, which is showing the pulse rate and the SpO2. The image on the right, I have taken just outside. So this is a small room. This is the machine, which is the MRI compatible machine. So you can use this. You can give sevoflurane, you can put in a supraglottic airway and then take an IV. Complications that can happen. There are not much complications that are being seen with the procedural sedation, but yes, hypoventilation, apnea, bronchospasm, laryngospasm, arrhythmias, bradycardia, hypotension, even allergic reactions. It can happen with contrast also, apart from anesthesia drugs. Aspiration, seizures. So now what are my challenges? My challenges are airway related. I might oversedate my patient. My challenges are equipment related, because that equipment need to be sized as per the pediatric. Then inadequate pre-procedural evaluation. There might be no backup plans. Then good communication, good assisting staff, the staff who is assisting me, and the one staff who is doing the procedure. The assisting staff should also be well versed with pediatric resuscitation and the pediatric airway management. Whosoever is giving sedation should be well versed in sedation, airway management of pediatrics, and pulse. Then drug side effects, because we are using multiple medication. Poor monitoring, post-procedural problems. Sedation is a stimulus-based thing. Once the stimulus is gone, after the procedure, the child is still sedated. The patient is still sedated. You need to monitor the patient. And they say that problems can occur 25 minutes after the last dose of medication. So after my last dose of medication, there are critical 25 minutes after the procedure, because now the stimulus is gone. So it is a stimulus-based sedation. And you need to titrate. You should always start with a low dose and then keep on titrating your sedative drug as per the procedure requirement. That what is my procedure requirement at that stage and what is the duration of that procedure. Then again, there is a controversy that where we need to observe the patient, whether the daycare admission should be there or not. Then post-procedure fasting, when it should be cut down. Because many times the child gets up, you have given just a sevoflurane and the child just get up crying. So what do? Then you have given IV midazolam, then also the child is crying after the procedure. So how soon you allow your fasting? I say after 1 hour, because or your airway reflex is intact and you have to give oral after the procedure under your supervision only. There can be procedure specific problems if you have given a contrast. They have to be careful about the pre and post procedure fasting. Who is the authorized person to give sedation? Again, there is a controversy about that, because it's a continuum of sedation. If we talk about the mild sedation says that it's a drug-induced state where the patient is arousable to the verbal stimuli. So till that mild sedation, that can be given by non-anesthesiologist, but again, that person should be well trained in pulse, well trained in airway management, apart from sedation. But you should understand that continuum of sedation says that any time from mild to moderate and moderate to deep, the patient can go, especially the pediatric age. So I think the authorized person should be an anesthesiologist. True that you are going out of your territory, you are going out of your comfort zone, and it's a multidisciplinary program. The patient has been admitted by someone else. The procedure is being done by IR people, intervention radiologists, and you are being called as an anesthesiologist to just give the sedation. And many times you are being told that you just give this drug, we'll manage the rest of the things. So we have to understand that as an anesthesiologist, this is left to me that what drug I have to do, because I know that this sedation continuum move from mild to deep, and anytime it can go from mild to deep. And daycare admission or OPD basis, we need to observe the patient for 2 to 3 hours after the procedure. So they should be admitted on a daycare basis or as per the hospital policy. Discharge criteria, you can follow modified Alder's code, the conscious level, the pulse rate, BP, saturation, because they should be able to ambulate. They should come back to their pre-sedated dynamics, stable pulse rate, respiration, no nausea, vomiting, distress, and you have to see their level of comfort so that they can go home. And they have taken something oral in front of you. Now the take-home message, yes, the choice of drugs. So you have to see the safety profile. You can use combination of drugs, but you have to keep in mind that whether you are doing that procedure as a non-painful diagnostic procedure or whether it is a minimal, moderate or severe painful. Because according to that, you have to choose your drug wisely to have a good safety profile, good onset and duration according to the procedure. And what are the special requirement of the procedure, whether you need to have something position, or you just need to blunt the airway reflex, or you just need to give this immobility, or analgesia is required. You have to allay any anxiety by the use of distraction techniques also. And there need to be a good communication and teamwork with the non-anesthesiologist or non-anesthesia person and non-OT staff also. And you should know where to call for help, whom to call, and how to call. Thank you. A happy child is a happy family.
Thank you, Niti. Thank you. Very comprehensively covered, Nora. And one thing to remember is that there's a very thin line between sedation and general anesthesia. That is something which is very important. And that is why you have to be very careful whenever you administer anesthesia to children, especially in the NORA areas. We will take questions in the end. I would request all people to post in their questions in the chat box. And so we come to the third part of our presentations. And in this, I'll be speaking now, and I'll be speaking on a relatively contemporary topic. I will not be talking on something very different like we have had presentations now. This is going to be a relatively contemporary topic, very important from the point of view of examinations. Anesthetic considerations in cyanotic congenital heart disease. That is the topic. So congenital heart disease are those malformations which are present at birth, which is of course understood from the word congenital itself. It is estimated that about 5 lakh adult patients with congenital heart disease are there in the USA. That means 5 lakh people are growing up in the USA to become adults from despite having congenital heart disease. And out of 25,000 infants added to the pool every year, about 85% are expected to reach adulthood. So 25,000 infants are added every year in the US to the pool of congenital heart disease. And out of them, 85% are now expected to reach adulthood. This population continues to grow in number, and the complexity is increasing, the age is increasing because they are surviving longer. So there's a requirement of ongoing specialized cardiac care, and this is going to expand over time. It is said that the incidence of congenital heart disease is 8 per 1,000 live births. And 25% of congenital heart disease patients have got some other associated anomalies, and many of them are syndromic in nature. Overall surgical mortality in such cases is said to be about 6%, but in a good center, the anesthesia-related mortality is said to be 0%. So in case it is 0%, we have to ensure that we have to give good anesthesia so that there is no mortality, and we should not be the odd one out. What are the factors which are contributing to the growing population among for non-cardiac surgery in such children? One is improvements and innovations in the surgical management. Surgical management is improving over the time, and so people are surviving longer. The variety and the complexity of surgical options have also grown. So surgeries which were shunned by surgeons earlier, they have become simpler. They have become, there are better ways of doing it, laparoscopic ways of doing it. So we are now indulging in surgeries in such children from various kinds of things. But remember one thing, very few patients who have had congenital heart disease can be considered as cured. No, you can say that no child who has got congenital heart disease can be treated as totally cured. They have some lesion, some remnant of the disease, or some sequelae of the disease which is persisting. The number of adults with congenital heart disease are going to grow. That means the children are the elder age group. That means that I would say that children who have passed the infancy and have grown into 11 years, 12 years, or up to 18 years, which is our group of discussion today, they're going to continue to grow over the time. And most of these patients may have undergone some kind of palliative or a corrective surgery procedure in their childhood. But despite this palliative or corrective surgery procedures, they are still receiving specialized medical care. So it is very important that once they've undergone a palliative or a corrective procedure, we should assess them properly so that we can manage them better. A few physiology points from children that you must remember when you're dealing with children with congenital heart disease. Remember that cardiac output gradually increases after the first few weeks of birth, number one. Secondly, the neonatal heart, in case you're dealing with a neonate for non-cardiac surgery, the neonatal heart is rate dependent and has got a cardiac output, a rate-dependent cardiac output, rather than a stroke volume dependent cardiac output. That means the stroke volume remains constant, but the rate is what decides the cardiac output. So you have bradycardia, you'll have low cardiac output. Another thing to remember is that the right ventricle is 2 times thicker than the left ventricle. And as a result, the compliance of the right ventricle, which is normally much more in an adult or in a normal person, is much lower than another person. So a child with congenital heart disease who's got a right ventricular hypertrophy, who very poorly tolerates increased in filling pressure, that means increase in fluids. The newborn heart typically works at the peak of the Starling curve. That means in case you got the Starling curve going like this, normally when you increase the preload, the cardiac output keeps on increasing. But the newborn heart does not have this part of the curve. It only works on the top of the curve, which is the peak. The stroke volume is relatively fixed, and as I repeat, the cardiac output is rate dependent. Another important thing is that the functional closure of the foramen well occurs at 8 to 24 hours, while the PDA closes at 24 to 48 hours. But in case the child has got shunts, and the shunts are not, have not closed down, or they are still functional, then this may not happen. The foramen well may persist, the PDA may not close down. So this is something to remember. The transitional circulation may revert back to the neonatal circulation in case the child has acidosis, stress, hypoxemia, hypothermia, hypoglycemia, or hypervolemia. A little bit about classification of congenital heart disease. I'm not talking about acyanotic heart disease, I'm talking about cyanotic heart disease. Now, cyanotic heart disease, children have been divided into 2 parts. Children with less pulmonary flow, in which typical is tetralogy of Fallot and tricuspid atresia. Then you may have a cyanotic child who has got a mixed blood flow. That means the shunt may be bilateral, or the shunt may be very complex in nature. So in that, we have things like transposition of great arteries, TAPVC, truncus arteriosus, hypoplastic left heart syndrome. The amount of shunting in the child will depend upon the difference between the systemic vascular resistance, the chambers in the vessels, and the size of the defect. Large non-restricted defects depend primarily on the difference between the systemic vascular resistance and the pulmonary vascular resistance. This is something very important to remember. If somebody got a large VSD or a large defect, very large shunt, then remember the shunting will depend on the difference between the SVR and the PVR. So your manipulation of PVR and SVR are going to make tremendous difference as far as the shunting is concerned. In case the defect is restrictive in nature, it primarily depends on defect size. Remember, anesthesia is more difficult in non-restrictive lesions, as the PVR and the SVR is always influenced by anesthetic drugs which we use. In case the child has got complex shunts, partial or complete obstruction along with shunt defect may be there. Partial obstruction may be dynamic or fixed, like as in tetralogy of Fallot, it is a dynamic kind of a obstruction, where because of spasm which occurs at the right ventricular outflow tract. The PVR and the SVR will influence the extent of obstruction, especially in a dynamic shunt. So this was general theory about it. Now let's come to the topic per se. That is children with right to left shunt, that is cyanotic children. Now, whenever there's a right to left shunt, it causes systemic hypoxemia, and the left ventricle gets volume overloaded, whether the shunting is in the atrial region, ventricular region, or at the vessel level. So left ventricle gets overloaded because there is shunting of blood from the right side to the left side. That is number one. Secondly, slight to moderate hypoxemia is well tolerated in neonates, but severe hypoxemia will always lead to acidosis and cardiovascular collapse. And in case the child has got a chronic hypoxemic state, then what will happen is, as a method of compensating, the body compensates by creating a state of polycythemia. There's an increase in the blood volume. There is increase in the vasculature, neovascularization, and the child tends to always hyperventilate because it is hungry for oxygen. And what happens finally is the hematocrit increases so much that it may exceed 60%. And once the hematocrit exceeds 60%, what happens is it increases the chances of renal and cerebral thromboembolic phenomena. You tend to have thromboembolisms, which especially affect the renal vessels and the cerebral vessels. There's an increase in the blood viscosity, increased vascular resistance. Already the blood is not going to the oxygenated blood is not going to the peripheries. In addition to that, there's an increase in the vascular resistance. The flow even gets slower to the peripheries. They tend to develop coagulopathies because the increased amount of hematocrit does not permit the WBC and the plasma component to expand in the blood. So as a result, they develop coagulopathies and they've got a decreased cardiorespiratory reserve. If the hematocrit of any child who comes with cyanotic heart disease, remember, if such a child has come, you should always do bloodletting and replace the amount of blood which you've taken with fresh frozen plasma. That is the best way of looking after it. Never try to anesthetize a child who's got a very high hematocrit with that particular hematocrit. You rather get after you induce anesthesia, do some bloodletting and replace that volume with fresh frozen plasma. That you can even replace it with saline or with ringer lactate, but the ideal way to do is with fresh frozen plasma. These children who are cyanotic tend to develop scoliosis in adolescence. It is said that 19% develop scoliosis despite having had corrective surgery in their childhood. So I'll come to one representative. I will not be discussing each and every cyanotic heart disease because they are very complex conditions, but one representative case, that is tetralogy of Fallot, because that's the commonest right to left shunt which you see. And not only is it commonest, but it is typically representing the entire cyanotic heart disease spectrum. So what are the 4 defects in tetralogy of Fallot? The first is, of course, a VSD. But I would say the primary lesion in this tetralogy of Fallot is right ventricular outflow tract obstruction. This is the state of there's a pulmonary stenosis. And in tetralogy of Fallot, it's a dynamic stenosis in which there is a subvalvular stenosis. The stenosis is here because of hypertrophy of the muscles just below the right ventricular outflow tract. So these are the 2 things which are there. And now what they finally cause is, they cause an override because the right ventricle tends to become bigger in size and the left ventricle is smaller in size. It is so what happens is they tend to develop what is called as overriding of aorta. That aorta tends to open more from the right ventricle side rather than opening from the left ventricle side. So that's called as overriding of aorta. And the 4th thing which happens is right ventricular hypertrophy, because there's a lot of load on the right ventricle to throw out blood from itself, and there's a lot of resistance to the outflow of blood from the right ventricle. They tend to develop right ventricular hypertrophy. In tetralogy of Fallot, the VSD is large but is always single. There's an infundibular pulmonary stenosis, and a bicuspid aortic valve is present in about 70% of these children. Because hardly any blood is able to go into pulmonary artery, the pulmonary arteries are hypoplastic in nature, or they may even be absent. Greater the pulmonary stenosis, the greater is the overriding, which I said earlier also. Right ventricular hypertrophy is there because of, as I repeat, because of high pressure load on the right ventricle. Cyanosis due to hypoxemia becomes apparent by 6 months of age. It may not be there at birth in a tetralogy file, but it appears generally by 6 months of age. And later on, clubbing appears. But clubbing does not appear before 6 months of age. So you may not see clubbing at before 6 months of age. Such children always have an ejection systolic murmur due to a flow across the infundibular pulmonary stenosis. Congestive heart failure is rare, as ventricular pressures equalizes due to the presence of a large VSD. So they do not go into congestive heart failure. Now they tend to develop what is called as TET spells or hypercyanotic spells. Now, the way to treat a child who has had a TET spell, this is a very common examination question. How do you treat TET spells? So the way to treat is to make the child squat. The child automatically, if the child is awake, automatically the body will take the child into a squatting position, this position, so that what it does is it folds the major arteries, and once the major arteries are folded, it increases this systemic vascular resistance and thereby shunts the blood more towards the lung and relieves the TET spell. Now, ABG in such a case will show a normal PCO2. That's very important. Normal PCO2, but the PO2 is low. And in 35% of cases, TET spells are provoked by exercise, crying, or due to sudden increases in SVR and infundibular spasm. What happens in all this also happens when the weather is very cold and the child tends to have severe, or the child is crying, and because there's a lot of adrenaline release, and that causes the spasm of the infundibular pulmonary stenosis. So treatment is maintain airways or hyperventilate the child, give bicarbonate to correct acidosis, compress the abdomen, aorta, or the arteries, use a drug to increase the SVR, that is phenylephrine, may be used, or use a drug which relieves the spasm of the infundibulum, that is esmolol or propranolol. Eliminate the stimulus which is causing it. So that is, in case it's during surgery, the pulmonary artery or the SVC is getting compressed, then you should remove the compression and give fluids. Sort of hemodilute the child by giving more preload. Now, another thing which is important is, why does the child with cyanotic heart disease develop polycythemia? What happens is, well, because of chronic hypoxemia, there is an increased release of erythropoietin by the kidneys. And this increased release of erythropoietin because of hypoxemia causes an increase in the RBC mass. Now, there's also a decrease in the 2,3-DPG levels, which causes a shift of the hemoglobin oxygen dissociation curve towards the right. There's an increase in a hematocrit as a result. But remember, though there's an increase in the hematocrit, the child is always iron depleted. There's actually iron deficiency in the child. The false, when you try to look for the hematocrit of the child, you'll get a false hematocrit. You may get it, the report may be much higher than the actual hematocrit because of plasma trapping in the tubes in which you've taken this sample. Because of the high hematocrit, there's a sort of plasma trapping which occurs in the tube, so you get a false hematocrit when you measure it in the lab. And this increase in hematocrit causes hyperviscosity, and the child gets symptomatic because of hyperviscosity if the hematocrit goes to more than 65%. And what happens what are the symptoms? The child will develop cerebral venous thrombosis. If the age is less than 4 years, beyond 4 years, generally cerebral thrombosis does not occur, and neither does it occur in adults. Again, remember, the PT and the PTT values are false because when you add the citrate which is fixed amount which is fixed in the tubes is not adequate for the hematocrit which is there in the child. So you'll get false PT and PT. So you'll think that the child is having coagulopathy. Actually, the coagulopathy may not be there. The PT may be actually normal, but because the citrate levels are low in the tube, that is why the PT and PTT may be falsely high. So I repeat, chronic hypoxia causes erythrocytosis, hyperviscosity, dehydration will worsen it, and all this will cause neurological and visual problems. So I repeat again, you should do an isovolemic phlebotomy. This is what is bloodletting. If the hematocrit is definitely more than 65%, and or if the child is symptomatic with a lower hematocrit also. We can bleed up to 5, depending on the size of the child, the age of the child, you can let out about 500 ml of blood and replace with FFP or 5% albumin. Remember that hemostasis mirrors the hematocrit. If the hematocrit is high, hemostasis will be disturbed and there's bleeding diastasis. The platelets will be low, but they do not cause bleeding. Bleeding in these children tend to bleed in case of any injury or any trauma is there or any surgical intervention is there, they tend to bleed. The bleeding is also due to increase in vascularity, as I said earlier, new vascularization, increased systemic pressures, and because also of aortopulmonary collaterals. Hemoglobin turnover is very high, so they tend to develop calcium bilirubinate stones. Apart from this, liver dysfunction is there due to and they have vitamin K deficiency and reduced coagulation. All these together cause coagulopathy. Right to left shunt also has renal effects. What happens is because of chronic hypoxemia, the glomeruli become hypercellular and the basement membrane tends to thicken up. There's focal interstitial fibrosis, tubular atrophy, hyalinization of the arterioles of the kidney. Uric acid levels tend to increase because of decreased excretion of uric acid. The children generally have arthralgia, but acute gout is uncommon. They tend to develop brain abscess and paradoxical cerebral embolisms. And what are the sources? Sources are air particles via the venous excess or from the lower limbs and pelvic veins. The emboli may go from the lower limbs and the pelvic veins. As I said earlier, adults are generally not at risk. They've got seizure disorders because of healed abscesses in the brain. They tend to develop brain abscess and they have got healed abscesses which causes seizure disorders. And they may have history of nerve injury due to prior surgery. That is, in case they've undergone a corrective surgery or a palliative surgery for the cyanotic heart disease, the recurrent laryngeal nerve particularly may be injured during the surgery, and so they may have nerve injuries. They may have phrenic nerve injury, which causes phrenic diaphragmatic palsy, especially in children who have had a post-BT shunt. If you look at the X-ray of the child, it is typically what is called as a boot-shaped heart. So you look at the boot-shaped heart. Typically, this is a typical X-ray of a child with a boot-shaped, and you have pulmonary oligemia. So the lung field appear almost black. You don't see the lines of the pulmonary vasculature. If you look at the ECG, they've got right axis deviation and right ventricular hypertrophy. So if you look at the transition of the waves, V1 to V6, you can see positive QRS complex in V1, which should be negative, and negative complexes in the V6, which is just the opposite. So it's a right axis deviation and right ventricular hypertrophy. The hypoxemia stimulates hydropoietin release, as I said earlier, and polycythemia comes. Viscosity, once it rises, there's a sluggish flow in the capillaries. So blood flow is very slow in this. And viscosity doubles when the hematocrit rises from 20 to 45. So that is why we have to hydrate them well. Apart from whatever I've said, polycythemia also causes increase in SVR and PVR, renal and visceral thrombosis, thrombocytopenia, clotting of shunts, and abscesses. What are the hemodynamic consequences of right to left shunt? There's decrease in pulmonary flow, there's hypoxemia as a result, there's a LV volume overload and LV dysfunction. A little bit about what are the palliative surgeries which are done from examination point of view. Very important to know. The examiner will ask you what is VT shunt. VT stands for Blalock Taussig shunt, and the classic VT shunt is an anastomosis between the right subclavian artery and the right pulmonary artery. So the anastomosis is done right here between the two arteries and the pulmonary and the systemic artery, that is subclavian. But what we do nowadays is called as the modified blood BT shunt. In the difference between the classic shunt and the modified shunt is that instead of directly anastomosing the artery to each other, you anastomose them with a Gore-Tex graft. That means you make a channel, control the amount of flow which is going from the systemic artery, the subclavian, to the pulmonary artery. Apart from this, two uncommon shunts which were done earlier but hardly practiced today, that is the pot shunt which is a shunt between the descending aorta and right pulmonary artery, and the Waterston shunt, which is from the ascending aorta to the right pulmonary artery. So what is the purpose of doing this palliative surgery? The purpose is basically to somehow send the blood from the systemic circulation to the pulmonary circulation so that some oxygenation can take place. That is the purpose of doing the shunt. As what is the PS? What should you remember in when you're checking the PSC? You should always look for what is the type of defect, whether any pediatric surgery or a corrective surgery has been done. What are the pressures in case they've been recorded by the cardiologist in the chambers and the arteries? What is the inotropic state of the child? And what are the gradients in the child, depending on the shunts? You should always do systemic examination of other shunts, and you should look at the hematocrit and the electrolytes. You should look at the past and present medication and look for neurological defects due to chronic hypoxemia. You should always look at the echo and the cath findings to see the diagnosis and the current status and the amount of and direction of shunt, the pressure and the oxygen saturation gradients in the chambers, QP by QS, PVR and RVOT gradient. Now, I'm not describing these things in detail because it may confuse you. Prophylactic antibiotics to prevent infective endocarditis is a must, because whenever there's a shunt, there's a lot of turbulence of blood, and which is likely to damage the endocardium and cause a nidus and provide a nidus for growth of bacteria. Appropriate drugs must be prepared with doses calculated well in advance. It should not be that you calculate the dose after the child is in. You calculate the dose before and take it. Remember, no pre-medication should be given to a child less than 6 months of age, because if you give pre-medication, the child gets sedated, the child is already hypoxemic, the child may just go off and become very severely hypoxemic. However, remember, the child is a little bigger, then pre-op sedation helps in reducing the dose of anesthetic agent, and it eases separation from the parents, apart from reducing induction time and smoothing the induction. Oral benzodiazepines are often preferred. As far as the hemodynamic goals are concerned, avoid increasing oxygen demand, maintain SVR and systemic blood pressure, minimize pulmonary vascular resistance, avoid dehydration, especially if the child is polycythemic. Theoretically, remember, inhalational induction is very slow as compared to IV induction in such children. But remember, clinically, it is not important. If the child does not have an IV, please go ahead, do an inhalational induction. Don't bother about it, because clinically, it is not so important. So in pre-medication, I said, good anxiolysis is important, in especially grown-up children. Continue the cardiac medication. Most of these children, especially children with tetralogy of Fallot, may be on some kind of beta blocker, especially propranolol. So in such cases, continue the cardiac medication. Use a drug like triclofos or oral midazolam to sedate the child. Induction will depend on the cardiac grade of the patient. If they're right to left shunt, avoid agents which decrease the SVR and the PVR. A ketamine induction is good, though ketamine increases the PVR and the SVR both. It is said that the induction dose of ketamine is not so great as to increase it too much. So we should not bother about this increase in PVR with ketamine, because it's otherwise causing an increase in SVR, and that is sort of taking off the load on the circulation. Narcotic induction is, of course, preferred, and IV induction is, of course, faster. In case the child has got a dynamic obstruction, preferably for induction, use a negative inotropic agent. So a negative inotropic agent like propofol and also thiopentone can be used in case you've got an IV in situ. In case the child has got an IV line C2, use IV ketamine in most cases. If there is no IV line C2, sevoflurane can be used on spontaneous breathing. Remember, ketamine increases heart rate, SVR and PVR in adults, but in infants, the increase is small and is safe. As far as maintenance is concerned, narcotic-based anesthesia is preferred because it avoids myocardial depression, and it can be used in all circumstances. Avoid bradycardia due to acidosis, hypoxemia, hypercarbia, and hypotension, because remember, bradycardia will cause a fall in the cardiac output. Something very important, it is essential to prevent air bubbles in all IV lines. when injecting drugs. Especially when injecting drugs, we have a tendency of injecting through the injection port of IV cannulas. Never do that. Always use a three-way and always aspirate before you inject any drug. By no chance should air go in a cyanotic child, because if air goes in from the right side, it will go to the left side and it may embolize to the cerebral vessels or any other important vessel. Use warm blood and fluids, and especially in case you're using rapid infusions, and always use filters for microaggregates. Because microaggregates again will tend to have a tendency of become macroaggregates inside the child and embolize. Avoid increase in PSCO2 and a decrease in PaO2 and an increase in PVR. Regional analgesia is acceptable as long as you do not cause hemodynamic compromise. Maintain SVR, maintain a VD by VT ratio of around 0.6 while you ventilating the child, because VD by VT increases with the start of ventilation. That is that once you start the ventilation, you may have more of dead space. So increases with also PEEP and also with hypovolemia. So remember, never try to increase the dead space in the children. Remember, there's a big difference between the EtCO2 and the PSCO2. Remember, in a normal child, the difference may be up to 5 millimeters of mercury, but because there's hardly any circulation in the lung, the EtCO2 is much, much lower than the PSCO2 in such children. So do not believe in the EtCO2 value, rather go in for a blood gas. Of course, standard monitoring has to be done. Apart from this, you also monitor the electrolytes. And post-operatively, PO2 responds very poorly to supplementary oxygen. So do not unnecessarily give supplementary oxygen to these children, because it will have more detrimental effects rather than good effects. Correct hypovolemia immediately. Do serial hematocrit evaluation, good post-op analgesia, and you should give good analgesia so that the SVR is low. Basically, especially in children with tetralogy of Fallot, you can reduce the SVR, you will have better outflows, and also in children with Eisenmenger syndrome. That's all. Thank you very much. I can understand that today we are late, and so we have exceeded our time. So I've tried to be as fast as possible, try to cover the subject as fast as possible. And in case there are any questions which are related to all three of us, you are welcome to please say them. Sanish, if you are aware of the questions, or if somebody from Clarnet can give us the questions which are there. I can't see anything posted by Clarnet, at least till now.
Yes, sir. There was a query whether opioid is related to today's topic.
Opioid is related to today's topic.
Yeah.
Today's topic.
No. Okay. Maybe something related to NORA. Somebody must have texted.
Yeah.
Okay.
Opioid is given if it is an analgesic is required. If it's a painful procedure, then we need to give an opioid.
Okay. Like in MRI and all, usually it's not required.
MRI it is not required. That was like MRI, we just need immobility and sedation. Only in the painful procedures it is required. Like we are going for ERCP or some biopsies going on, like CT guided biopsy.
Both talks were excellent. Thank you.
Thank you, sir. I think you joined late. You didn't hear the first talk. That was also good, sir.
Sorry, I missed the first one.
Yes, sir. So nice to see you, Dr. Gulati. It's nice to see that. I think it must be in the daytime for you and a working day. Good to see you in the audience, sir.
Yeah, it's morning, and I was busy during the first time. Now I have a little break, so it was good to listen to your talks. They were excellent.
Thank you, sir. Thank you very much.
Thank you, sir.
In case there are no questions, can I hand over the proceedings to Sanish? Sanish for summing up and closing.
Fine. As Dr. Belani said, it was a nice, interesting session. I think to sum it up, sir, you have got a wonderful team with you, sir, Mukul sir, because we enjoy having webinars from Amrita Institute from Faridabad. And I think I'll make that announcement now. 1 second. Because next week also we'll have a webinar from Dr. Mukul Kapoor's department. That will be on neuroanesthesia. So we'll circulate the details very soon. Today we had a wonderful session starting with our non-technical skills in pediatric anesthesia by Dr. Ketan. I think he was faculty for ICA webinars before also. We got very nice responses to his lucid talk, and today we got to see video demonstrations as well. Thank you, Dr. Ketan.
Thank you.
And Dr. Niti actually had a tough topic of NORA, and that too with pediatric population. So that is very interesting and very informative also. Thanks a lot, Dr. Niti.
Thank you.
And of course, our masterclass educator academician, Dr. Mukul Kapoor, summing up on the consideration regarding the cyanotic congenital heart diseases. We look forward to hearing from Team Amrita in our next webinar as well. Before concluding, let me remind you that our ICA webinars are on air on all Wednesdays evening, but virtual meetings are virtual meetings. It's time to come together, meet in person. So our ICA, our national conference, 14th national conference and 4th international conference of Indian College of Anesthesiologists is coming up 2nd to 5th of November in Bangalore. Please note the date and please make it a point to attend in person. So thank you very much for attending today's session. We look forward to your company in the next sessions as well. And special thanks to Dr. Kumar Belani, our Dean International, for joining us in this session. Thanks a lot. Good night and goodbye. See you next
Thank you,
week.
sir.
Bye.
Thank
And
you, sir. Thank you.
since it was live streaming, we have received some not questions, rather very informative, very excellent presentations and all to all our respective speakers.
Yeah. So, okay.
Thank you.
Okay. Thank you.
Thank
Thank you to
Thank you.
everyone. Good night to all.
Good night. Thank you.
Thank you.
Good night.